Everybody, good afternoon. Now we have come to the third session of our IECO India on the topic of infection control program. So can you please put the agenda? Now, in the technical session of this module 2 on infection control, we have a personality with masters in child health nursing. Her name is Miss Smita Bamase, and she's an associate professor in K.J. Somaya School and College of Nursing, Mumbai. We welcome you, ma'am. We know that you have 13 years of teaching experience and 3 years in clinic. Yeah.
Thank you so much, ma'am.
Sorry for the delay.
No, it's okay. It's okay. We can understand. Ma'am, you want me to start the session?
Yes, ma'am. Then we'll have the case presentation.
Okay, ma'am. Just let me share my screen first.
Yes. All participants, please keep the video on.
Can you see my screen?
Yes, ma'am.
Thank you so much, ma'am, and thank you, Alvin sir, for giving me such an opportunity to present my topic today. And I think this is the first time after MSc I am taking lecture for Goa Nursing Council. Thank you so much. So today's topic, it's not a new topic for everyone. It's a topic because you all people are working in the ward and we all are practicing the same thing. Only thing is that somewhere we have to polish our thing, and that is what I'm going to do today. So today's topic, as you all know, the session is infection prevention and control practices for nursing professionals. First, we will see the learning objectives. After this module, the participant will be able to understand standard precaution, hand hygiene, PPE, respiratory hygiene and the sharp injuries. Now, I don't think we have to so much discuss about the standard precaution because it is universal, everybody knows it. What is standard precaution? It is a set of guidelines to prevent healthcare worker exposure to infection which can be transmitted by body fluids of patient. Primary strategy for minimizing the risks of transmission of microorganism in healthcare facility. So we are working in the ward and we are having this, we know that standard precaution what we have to maintain, and we are doing that also. Okay, so it need to be followed for all patients irrespective of their infectious status, whether the patient is infected or non-infected, still we have to take care of all these things. To avoid contact with body fluids, blood, non-intact skin, mucous membrane secretion and excretion. Now we will see what are the component of standard precaution. First and foremost is a hand washing. The basic things which we used to do in the hospital whenever we are doing any procedure or after any procedure, we have to follow the hand washing. Second is the personal protective equipment. Now previously we were knowing about the PPE. Okay, in some of the areas we are following, but after coming COVID, in every ward also we are following the PPE. Okay, respiratory hygiene and cold. Third one is respiratory hygiene and cold etiquettes. Fourth, we are also going to see about the prevention from sharp injuries. Fifth, safe handling of patient care equipment. Sixth, principles of asepsis. And seventh, environmental infection control. Now we will see one by one. What is hand hygiene? It is everybody very well known. That is a hand transmission. Important and effective method of preventing transmission of infection in healthcare facilities. So everybody knows whenever we are going and touching the patient, before that we used to do our hand washing. Then after touching the patient or any surfaces, we are having the hand washing, and everybody knows we do our hand washing with the soap and water. But sometimes it is not possible. In that cases we use the sanitizer, but our main focus is we have to wash our hand in order to prevent the cross infection, and we have to protect ourselves and our patient. Hand contamination can occur through patient, their environment and other healthcare workers. Remove transient microorganism, dust and organic material from the skin and reduces cross contamination. So that's why hand hygiene is very important. Sometimes it happens we used to take care of the patient even though we just go and talk to the patient, but while taking the medication or something like that, we are touching the surfaces, then also we are supposed to do our hand washing. Now, poor adherence to hand hygiene. The main reason for poor adherence, that is a lack of knowledge. Even though as a nurse, if I am saying that, many times we used to repeat that, "Arey, hand hygiene karna hai, hand washing should be done." I know all are busy. Sometimes there is an emergency. Sometimes after knowing also we are forgetting and we are keeping aside. Okay, let it be. I will do it afterward. So please see to that. You should not do like that. You have to focus whenever you are touching the patient, when you are treating the patient, whenever you are doing any kind of a aseptic technique, you have to have a hand washing. Lack of participation. Many times what we have seen that there are rules and regulation, there are the protocols are there, but people are not participating, they are not following the things. Okay, then lack of administrative support. Administrative supports in the way, I'll just give an example with you. We are working in the ward. Sometimes from managerial part they says that in the hand washing area we are supposed to have a soap solution. Okay, but actually sometimes when we go to the ward, sometimes the soap solution is finished or it is not there. So because there is a lack of administrative support also, so we require that also. And staff to patient ratio, we have to see that how we are managing this ratio, because this is again it is going to help to prevent the infection. Next is lack of encouragement. Okay, if you are doing the good things also, if nobody is appreciating you, then you will not get motivation. Then there is a lack of supply, as I already told that if there is a no supply, if the administrative people are not supporting you, if they are not giving you proper hand washing areas to you, again there will be a problem. Then lack of reminders. Reminders in the sense we can see whenever the hand washing areas are there, we are supposed to have posters. So this becomes a one kind of a motivations, one kind of a things also we will see those who are coming, the newcomers or the students also working in the ward. Okay, they also can see the with the help of flashcard, and they will follow the steps. Then allergens to hand washing products. So we have to have a alcohol which will be not allergen to people. Now this is the basic things we all used to follow. In a diagram, it is well explanatory. When to do hand hygiene. I'll just focus which are the when you are supposed to do. First, before touching a patient. For example, if you are going and approaching the patient, before that you are supposed to do the hand washing. Second, before clean or aseptic procedure. Okay, so whenever you are going to do any kind of food like a dressing or something wound care, so your hand should be washed. Third, after body fluid exposure or a risk. Okay, so whenever you are touching any kind of body surfaces, immediately you go and you do the hand washing. For example, if you are changing the urinary drainage, okay, so emptying that bag, in that cases also, if you are touching the wound drainage bag, that time also you are supposed to wash your hand. And after touching a patient, okay, it is going to be safe for you also and making safe for the patient also. And fifth, after touching patient surrounding, any kind of a surface area where we are going to touch, even for the bed also, we have to do our hand washing. So I hope everybody should remember these are the 5 things which we have to follow in the hand hygiene. Now this everybody must have seen in your also hospital, wherever the whichever the area washing areas are there, because it is nowadays mandatory. All the washing areas, there is supposed to be a flashcard, okay, where the steps has been shown. That is a hand hygiene which we will do with the soap and water. So basically the duration will be yours 40 to 60 seconds. First, as you everybody knows, you have to wet your hand, apply the enough soap, then you have to rub your palm to palm, then your back dorsum with the interface finger, okay, then palm to palm with the interlace, okay, then back to back the finger, then your this rotation wise you are going to do your thumb, okay, then rotational rubbing backward and forward with the claps finger, okay, and rinse your hand with water. You have to dry it thoroughly, because again if it is moisture will be there, there are the chances the microorganism will be there. And use a towel, okay, whenever you are going to close the tap, and then you have to dry your hand, so then you can say you are your hands are safe. Now when we are supposed to do it, hand washing, there are the indications, okay. Indication means in which condition we are supposed to do it. First, when visible heavy contamination, whenever you see there is your hands are dirty, it is come in contact with any kind of a body or fluid or any secretion, immediately we have to do the hand washing. Second, after attending to a patient with suspected confirmed Clostridium difficile infection, that is a dysentery or diarrhea patient, in that cases also you have to wash your hand. After using toilet, before and after having food, an adequate number of sink with running water and soap should be available at the healthcare facility to facilitate hand washing. Now, in areas where you don't have a soap and water, or you have a soap and water but immediately you have to provide a care to your patient and the time duration is less, so what you can do in that time, you can have a alcohol based hand rubs, okay, which we all are doing after the COVID have come. Mostly we are focusing on that. If I ask, nowadays every bag still they have a sanitizer with them, yes or no? Okay, so here the duration, as we have seen, the duration is 40 to 60. Here the duration will be yours 20 to 30 will be there. The steps will be the same as what we are going to do in the hand washing with the soap and water. Alcohol based hand rubs, the advantage is easily accessible. You can keep it in your pocket, or you can keep it in the patient's bedside areas also. You will see the hand rubs are there. The second advantage, it is a great antimicrobial activity against the gram-negative and gram-positive bacteria or viruses. The disadvantage is It is less effective against non-enveloped viruses or bacterial spores and protozoan oocytes. Now coming to the surgical hand rub, done before any surgical procedure. For example, in OTs and all you have seen, and sometimes if you are going to do a bedside like a aseptic technique, in that cases also we have to do the surgical hand rub. It reduces the microorganism which will inhibit growth of microorganism, and basically we use the product that is chlorhexidine and povidone. Improving implementation of hand hygiene. System change. First, access to continuous supply of water and soap for ABHR and towel present at the point of care. Most of the time we have seen, okay, कभी साबुन नहीं रहता है, तो कभी टॉल नहीं रहता है, तो कभी सैनिटाइजर नहीं रहता है. That thing should not be there. So those who are working in the ward, you have to see that each area the supply should be there. If it is going to be empty, see to that it should be refilled immediately. Training and education. Teach 5 moments of hand hygiene and the correct steps. Now 5 moments of hand hygiene I have just told you. Whenever you are going to approach the patient, you are touching the patient or any surfaces, you are doing any kind of a procedure, your hand washing should be must. Then evaluation. In that, monitor the hand hygiene practice and infrastructure should be there. Then you have to provide reminders, institutional safety climate. You have to create an environment that raises awareness. More people should participate. It should not be kept with you, but when we are working in the ward, we have to teach the relatives, we have to teach the patient also the same thing. Fingernails in hand hygiene. Fingernails has an impact on transmission of infection. The type and the length impact hand hygiene. As everybody know it, and we are following in, even though in the teaching areas or in the clinical, those who are working, we always see to that our nails should be cut in order to have a good hygiene, and we should not give any patient or any others microorganism or a cross infection. Personal protective equipment. Barrier protection. It protects from exposure to infection from environmental and infectious agent. Used to protect mucous membrane, airways, skin and clothing from infectious agent. So everybody, we are those who have worked in the COVID areas and all, okay, they are very well known about the PPE. So in the PPE, what are the types are there? First is the gloves, which will help to protect our hands. Second, gowns and apron. Everybody knows whenever we are coming in contact with the secretion or a splash, something like that, we have to wear a gown. Then next is the mask. Mask should be always wear. Those who are working in the healthcare worker, they are supposed to have the mask, okay. It will protect your mouth and nose, because sometimes it is not necessarily the patient or is infected. Sometimes we are also infected and we are going to give infection to our patient. Then third is the respiratory. Protect respiratory tract from airborne infectious agent. Goggles. Goggles, it should be protect the eyes, and the face shield protect face, mouth, nose and ear. Now there is one case study which I wanted to read out. Sam, a nurse who is working in the emergency department, has a patient arrive who has an open drain wound on her abdomen, and the temperature was 38.9 degrees centigrade, and there was a foul smell on her abdomen. A recent culture has been taken and it shows that there is a MRSA, that is methicillin resistant Staphylococcus aureus, in patient wound, and patient is 15 days post-operative from cesarean section. So I would like to ask you, what PPE should be used and why? Yes, can anyone give me the answer? I hope all are attending. I know it's a post-lunch session, so I don't want anyone to sleep. It should be interactive session, because this and all we are working in the ward, so your active participation is necessary. Yes, anyone from the participant? Just now we have seen what are the PPE and what we are supposed to use in this case. Yes, anyone? Or you want to write down in the chat box? Okay, some people they have given the answer gloves, mask. That is right answer. Okay.
They will enter in the chat box, madam.
Yes, yes, I have seen, ma'am.
Okay, fine.
So what you have given the answer, that is right. Next is the personal protective equipment. In that, what are the factors it has to be considered? Type of substance, body substance which is involved. As per that, we are using the personal protective equipment. Then probability of possible transmission of route from which it is going to be transmitted to ourselves and the patient, and probable risks of exposure to blood and bodily fluid. So these are the factors. whenever ऐसे नहीं कि नॉर्मल भी पेशेंट है, we are wearing the personal PPE and then we are, it's so costly. When we are utilizing any kind of a thing from the hospital, we have to understand the administrative point of view, the economic point of view also. So wherever there is necessary, we have to use it. Now seeing the gloves first, clean non-sterile gloves. In which are the things where we can use it? First, whenever we are going to have a contact with the blood or body fluid, secretion, etc. Whenever we are conducting any kind of examination which are non-surgical procedure, and healthcare worker have non-intact skin, in that cases we are going to wear the non-sterile gloves. Now sterile gloves, everybody knows that whenever we are going to have a aseptic procedures, in that cases, for example, you are dressing and all, or doing the catheterization procedure, in that cases we are going to wear the sterile gloves. Heavy duty gloves are worn for decontamination of the large equipment or cleaning of floor, walls or furniture such as bed and chairs, and reusable. Do's and don'ts of gloves. First, work from clean to dirty. Limits opportunity for touch contamination. It is going to protect yourself, others and the environment. And it should not be touched to your face. Don't touch your face or adjust PPE with contaminated gloves. Basically, I have seen my students also doing the same mistake after telling them also. Wearing the gloves, okay, even though if it is a clean gloves, okay, gloves तो wear किया है, they know that it is for the sterile thing, but still they used to touch here and there. क्यों? मैम gloves पहना है ना. अरे gloves पहना है तो that gloves is for the aseptic procedure, not to touch here and there. So you have to be very much clear about how to use it. Don't touch environmental surfaces except as necessary during the patient care. Change gloves. If you see the gloves is torn somewhere or heavily soiled, so you cannot use, even when you are doing the dressing for that patient and you have seen so much of blood is there, change the gloves immediately and wear the another gloves. After, even for that same patient, after use on each patient, you have to change the gloves if it is necessary. Okay. Then discard in appropriate receptacles. Never wash or reuse disposable gloves. Now coming to the face protection. Eye goggles. Eye goggle, it is going to protect the eyes from splashes and should fit snugly around the eyes, and prescription glasses. Personal glasses or goggles are not replacement. Otherwise you will think, अरे मैंने तो चश्मा पहना है तो मेरे आँख पे तो नहीं आएगा. No, it should not be. Because when you see that the goggles are fitted properly, it is going to cover the major area of your face. Face shield. It protects skin, mouth, nose and eyes. It is going to cover the forehead, extend below the chin and wrap around the side of the face. It is protects skin, mouth, eyes, nose and eyes. As I told you that cover forehead, extend below the chin and wrap around the face. You must have, those who are working in the ward, they have used also this face shield. Very, very important. It protects mucous membrane of the mouth and nose during procedure that are likely to generate splashes of blood, body fluid, secretion and excretion. Surgical masks are designed to resist fluid to a certain extent. Face in that surgical masks are disposable. Once you use it, discard it. Can be used to protect against airborne and droplet precaution, and it can be used by the patient and the hospital staff also, and it is a loose fitting. Consideration when using a surgical mask: if it is a soil or weight, we have to change it. Never reapply once it has been removed because it is going to be contaminated. And we have a habit of always, what we used to do, we wear the mask, and what we used to do, we used to dangle the mask around the neck. So what happened over here, when you are doing, you are contaminating the other areas also, and there are the most chances that you're also going to get a infection. So do not dangle mask around the neck. Do not touch your mask when wearing. Perform hand hygiene whenever you are wearing and discarding a mask. Face protection. Respirators. Protect from inhalation of infectious aerosol. That is, everybody's knows, okay, N95 respirator. Okay, it can filter 0.3 micron diameter particles. The indications are, whenever there is a airborne transmission of diseases, we have to wear a N95 mask. Whenever we are performing any kind of a aerosol procedure like bronchoscopy, we have to wear a mask. Or if you know that a patient is infective and there are the chances from whom you can get the infection, as it is a aerosol, you have to wear a N95 mask. Now, face protection, in that training should be there. How we are supposed to put the respirator, how to perform the seal check, how to avoid the contamination, and how to change the mask whenever it is dirt. So there is one again second case study. You are visiting a friend who had just had a surgery. While the surgeon is making round, you see the physician put on gloves and then inspect your friend's wound. When he is finished, he does not remove the gloves or perform hand hygiene. Instead of that, he goes over to inspect the wound of the person in the next bed. Now, in the beginning only, I have shown you what are the 5 movements of hand hygiene. Yes, everybody knows. There are the 5 things, okay? Before touching, after touching, any surface area, while performing the procedures, okay, while changing the body fluids, you have to wash your hands. Next, respiratory hygiene and cough etiquettes. This is what we have learned from our, when we are in the school age, that time also we have learned, whenever we have to cough, sneeze, okay, we have to use like this, okay. Measure to be taken: an infected person having signs and symptoms of respiratory infection to limit transmission to other person. Recommended measure: cover the mouth and nose while coughing or sneezing. Basically, we used to have a tissue paper, or sometimes we used to have a handkerchief with us. Disposable tissue after use. Dispose the tissue whenever you are using, and perform the hand hygiene after using the tissues, because tissues, it is there the microorganism, but you are touching that area, that means your hands also are contaminated, so you have to wash your hand. Then keep the materials like tissues, foot operated waste bins and alcohol based hand rubs ready for respiratory hygiene. In that cases, if you don't have any soap solutions, or you are not able to reach till you have a hand hygiene, that is sanitizer, you can sanitize your hand after disposing the tissues. In the absence of tissues, you use your arms to cover your nose and mouth while coughing or sneezing. Wash basin with soap and water should be present at convenient location for the hand washing areas. Okay, I think after COVID, before whenever we used to meet, what I remember is we used to shake our hand. But once the COVID came, okay, we try to avoid shaking our hand. Instead of that, we are using our namaste. Yes or no? So this is also one kind of good practice which we can do in order to prevent the infection. Next is poster should be put at a regular interval near the OPDs, emergency department, doctor's clinic, etc., highlighting the respiratory hygiene and cough etiquettes. And what I have also observed, and we are following also the same protocol in all the hospitals. And poster should be there in the local language so that the people can understand. Coming to the prevention of sharp injuries. Handling sharp is one of the hazardous activity for healthcare worker, because many times we used to get needle stick injury. So we have to be very much cautious whenever we are using the sharp article. Broken and bent needle should not be used, and it has to be disposed. Use needle in a puncture-proof bag with biohazard symbol. Now, by seeing this diagrams, it is very understandable how you can use whenever you are having a single hand scoop method. Okay, so placing the cover and then putting the needle with one hand. Okay, can you see it? Sharp should be used once. Ensure the point ends of the instrument are away from oneself and the other, so it is not going to injure any other people. Contact admin point of person when injured or sharp. So whenever you have a needle stick injury or something you had happened with the sharp, you immediately have to report your seniors, okay, and you have to follow your institutional protocol. Injection safety, important component of standard precaution. Use new injection device for every procedure. Ensure the packing of injection device is sealed. Do not use the injection device if package is punctured, torn or damaged. I think we all are following the same thing. For each and every patient, we are using the disposable syringe and the needle. Single dose or a multi-dose vials. Use single dose for each patient to avoid cross-contamination. Open one vial of medicine in each patient care area. When using multiple vials, label the patient name. Never leave the needle or the cannula into the medication via the rubber stopper. Multi-vial should be discarded within 28 days of opening, even when under expiry date. So basically what I mean to say that we all are giving injections in the ward. But what I have observed, okay, whenever I used to go and take the round, the students are doing the mistake, even the staff also too. They are diluting the injection. They know which patient they have to give, but they never ever used to do the labeling, which is very important. So our staff nurses are lacking in recording, reporting, labeling, which we have to follow each properly, because you never know if you have prepared and someone has taken that tray, and if that wrong injection, if it has been given to the other patient, the patient will have a problem. So as we are dealing with the human beings, so proper labeling is must with the patient name and the injection name and how much ml it is, it has to be there with the date. Labeling. After reconstitutions of a multi-dose vial, label the final medication container. So what are the things supposed to be there? Date and time of preparation, because many times it happens, sometimes emergency thing has come or staff are busy in some other work, they have prepared the diluted medications and they have kept in the pie dish. Okay, maybe the patient has gone for the x-ray. They thought that when the patient will come, that time I will give the injection. Still that injection is on the pie dish. So if you are going to keep for longer time, you don't know at what time the preparation has been done. So if it is like that, only the potency will go, and when you are going to give the injection to the patient, the effect will not be there. So it is very important. You have to write down the time of preparation, then the final concentration, the expiry date and time, and name and signature of the person reconstituting the drug. It is very important. For multi-dose medication that do not require constitution, add a label with date and time of first piercing the vial, because most of the time we used to dilute the medication, for example AZ or something, the antibiotic dose and all, we used to dilute the things. ओके 10 ml में ही डाइल्यूट करके दिया एंड 5 ml मैंने अभी दिया, उसके बाद सेकेंड डोज आई एम गोइंग टू गिव टुमारो. सो प्रॉपर लेबलिंग शुड बी देयर. ओके, with your signature when you have done this, every detail should be there whenever you are going to do the labeling thing. Preparing injection. Before giving the injection, clean the site with 70% alcohol solution. Ensure all equipment needed for injection like sterile single use needle, alcohol swab, reconstitution solution are assembled. Do not use alcohol skin disinfection for live agitated vaccine, and do not pre-soak cotton wool with disinfection solution. Many times what we have seen also, I'll just share one more example with you, that we have taken the sterile cotton, okay, and when you wanted to give a intramuscular injection, so that sterile cotton, sometimes you will clean the area, okay, and sometimes what happen, you have taken the cotton and you are keeping on the patient's bed, so that should not be done. If you are taking the sterile one, see to that the sterility should be maintained. Use on the sterile cotton. If you have used it, throw it. Do not use the same cotton which you have cleaned, otherwise there are the chances you are making the virus or bacteria, microorganism to enter the patient body. We are not supposed to give a nosocomial infection to our patient. Administering injection. Always perform hand hygiene before administering injection. Disinfect the vial before using it. Use sterile needles and the syringe to withdraw medication. If injection cannot be administered, then cover the needle with the cap using single scoop method. Again, you have to remember the single scoop method, which I have already shown to you on the diagram, and store injection in a dry kidney dish. Don'ts for injection safety. So what you are not supposed to do it. Do not allow the needle to touch any contaminated surfaces. Okay. Most of the times what we have seen, blood sample भी लेने जा रहे हैं या फिर इंजेक्शन भी देने जा रहे हैं, पाई डिश में रखते हैं या staff they will carry that injection in their hand and they are keeping the injections on the patient bed, and after that they are giving the injection. Should not be followed. Even though for the interns, doctors also I have seen, whenever they are going to give taking the blood sample or या फिर वेन फ्लो अगर आपको लगाना है न्यू, तो what they used to keep on the bed. Patient का bed is not a sterile area, it is a contaminated area. How you are going to keep it over there, and with that you are cleaning also. After cleaning, when you are closing that the things, that also that time also sample लिया तो उससे ही आप ये बंद भी कर रहे हो. So that means how much of you are giving the exposure of microorganism to the patient's body. So you have to think about it. Okay. Reuse a single syringe even if the needle is changed. Then touch the diaphragm after disinfection with 70% alcohol. Use the same needle and the syringe for do not use this same needle. This is I am talking about the do not. Okay, I have not used the word here again and again, do not, so you don't understand use the same needle. That is, do not use the same needle and syringe for several multi-dose vials. Do not use the same mixing syringe to reconstitute several vials. Do not use bag or bottles of intravenous solution as a common source of supply for multiple patients. Do not use a single loaded syringe to administer medication to several patients. Do not change the needle to reuse the syringe, and do not store leftover medication for later use. I know we all are following the same thing. These are the safety of injection. Aseptic guidelines. The operating room disinfection is required before the start, between and after procedure, and at the end of the working day. The disinfection of all surfaces and all surgical items including all annexes should be done. The surgical instrument required should be sterilized, and once the sterile drape is used, it should not be touched. So I think everybody is following the same aseptic guidelines everywhere. Okay. Surgical hand rub should be followed before the start of any procedure, and sterile gloves is to be used. Follow double gloving for high risk procedures, and if they are punctured, immediately remove them and follow protocol for the needle stick injury. And sometimes if it is a contaminated or dirty, your gloves are more dirty, so immediately you have to remove the gloves and wear the another gloves. Then surgical mask should be cover the mouth and the nose when it is in operating environment. The take home message for today's session is standard precaution are the basic of a good infection prevention program. You have to follow the hand hygiene before and after the procedure, or meeting with the patient is an effective way of limiting the transmission, and PP kit are the barriers which is going to protect the healthcare worker. Okay, so the safety is in our hand. It is only we know how to use it for ourselves and for our patient. Thank you so much. If anybody have a doubt, please ask me. Any questions? I hope you all have understood this session, because I think this is everybody is doing in their institution. You are doing all this work. It's just polishing to your knowledge, I think so. And wherever we feel that we are going something where wrong, like not maintaining the sterility properly, or we are not following this standard precaution, we have to be much careful about all this thing.
Yes, ma'am. Thank you for your this on prevention of infection and infection control. It was a nice session, madam. Any questions, participants? Do you all have any questions? Madam, thank you for elaborating on hand hygiene.
If there is no question, then everybody understood. If there is no question, then nobody has understood also.
No, we understood, madam. It was just a brush up of our knowledge.
Yeah. Yes, it's a brush up of your all knowledge, because we all are following the same thing, but some or other times we tends to do mistake. Okay, this only thing is that we have to keep in mind that we should we are dealing with the human beings, and whenever we are treating the patient, I am always teach my students, consider they are your family members. Think about that whenever you are going to do anything, so that there are less chances of doing the mistake. That's it.
Yes, madam.
Thank you so much.
Moreover, the participants are all from the teaching faculty. So it will be good for them to tell their students and teach their students
Yes.
more this.
Yes. Thank you, ma'am. Albin, sir,
Thank you, ma'am.
you want me to continue or shall I leave?
Yes, ma'am. There will be a case presentation now. So
Okay.
the case presentation, if they want, there will be any discussion, require your support.
Okay, fine. So I will wait then.
Thank you.
Thank you.
Now we'll have the case presentation. Over to Madam Sierra, which will be presented by Sulaksha Desai, and she's a teaching faculty from the Department of MedSurg from the Institute of Nursing Education, Bambolim. And Madam
Hello.
Sierra will coordinate with this.
Hello, good afternoon. Sierra here. Hi, Sulaksha. Hi, Sulaksha. Can you start with the case presentation?
Yes, ma'am. Yes, ma'am. Good afternoon, everybody.
Good afternoon.
Respected Dr. Sanjay, Dr. Rati Balachandran, Madam Smita Barmase, Sir Albin, Goa Nursing Council Registrar, Madam Flossie, and all my dear colleagues. I would like to thank Eco India and Goa Nursing Council for arranging this webinar for us and giving me an opportunity to present my case. Since the topic is infection prevention and control, I have taken burns unit as my case scenario. So I have tried to correlate all the concepts of infection prevention and control discussed in the previous 2 modules and present before you the practical realities of this ward. Next slide, sir. Burns Unit Ward 117 is a critical care unit of Goa Medical College and Hospital, Bambolim, Goa. It is a special super specialty unit having a bed strength of 12. It is self-sufficient in all respects of burns management. It has a casualty, 6 isolation room, 6 step-down beds, dressing room separate for inpatient and outpatient clients, operation theater, physiotherapy, as well as occupational therapy sections. Next, sir. This is the next, sir. This is the pictures of the unit, burns unit. This is okay, step down operation theater. Next, sir. So the unit also has cardiac monitors and ventilators to manage patients when they are critical. Burns patients are at high risk for all types of infections due to their impaired primary and secondary defense mechanisms because of the skin injuries which they have on their body. So infection prevention and control becomes the integral part of a burn unit. Protocols and the policies developed and practiced by the professor and the head of burns unit, Dr. Yuri Dias, ward sister Margaret, and their team are worth to be appreciated, which we are going to see in the future slides. Infection prevention and control practices of burns unit of GMC Hospital, Bamboli. According to the WHO, IPC practices help to prevent harm caused by infection to patients and health workers. The various IPC practices taken up by the burn unit can be categorized as surveillance practices, prevention practices, and control practices. Next slide, sir. Surveillance practices taken up by this ward are twice a month sterility testing is conducted by exposing the petri dishes in the different areas of the burn unit to test the growth of microorganisms. And the CVP line catheter tip of every patient is sent to microbiology to test for presence of microorganisms. Prevention practices. Prevention of infection depends on appropriate clinical practices in all routine patient care. The practices followed by this ward include strict barrier nursing and PPE use to receive the patient in casualty. A throat swab is collected to check for COVID-19 infection on admission. Only COVID negative patients are shifted to the burn isolation room and cared. COVID positive patients are cared separately. Hand washing and all standard precaution used before and after caring for patients. Bedridden patients are given a shower bath in bathtub, while those patients who are mobile are given bathroom bath before doing an aseptic dressing. Accurate infectious etiology is diagnosed and judicious antimicrobial selection and utilization is done to prevent infection. Prevention of lower respiratory tract infection in ventilated patients is done by giving nebulization, chest physiotherapy, and antibiotics. Since the physiotherapists are there, they come on round and teach the patient all physiotherapy, chest physiotherapy, like deep breathing and coughing exercises. Next, sir. Catheter-associated urinary tract infections, COTI, is managed as follows. Only those patients who require catheter are catheterized. Insertion of urinary catheter by using aseptic technique. Daily catheter care is given with Savlon, and all the staff see that a closed circuit is maintained for the urinary bag. Silicone catheters are changed every 28 days. If the patient has catheter, then the silicone catheters they change after 28 days, but the rubber catheters are changed after every 14 days. Central line associated bloodstream infections. Prevention strategies include everyday CVP line catheter side dressing is done. Strict aseptic techniques are used while handling the CVP line. CVP catheter is removed, or if it has to be there for the patient, then the CVP site is changed and another CVP line is pushed after the 14 days. Next slide, sir. Next slide. Now, control practices which are carried out are general measures to control infection in burns include staff strictly follow the guidelines of biomedical waste management to handle the waste generated in the unit. Supervision of waste management is allotted to an assistant lecturer. And also nowadays, the GMC has a separate faculty who come and see whether the waste management is segregated properly. Staffs undergo in-service education to update their knowledge on various aspects of patient care. Dr. Yuri specially conducts various in-service educations for them. Fumig spray, that is ethanol, 2 propanol, 1 propanol, is used to clean instruments and electronics. On admission, patients and relatives are taught about waste segregation. This is one important thing because waste management is not a single person work. It is a teamwork, and even the patient and the patient care are the part of this team. So the patients are educated on waste segregation on admission. Next, sir. Healthcare personnel and relatives entering the unit wear separate gowns before entering the unit. Gowns are sent for washing every day. Monday and Thursday, sharps are emptied. Carbonization of the door handles, trolley, etc. is done. Physiotherapists wear gowns while attending the patient and change gloves after every patient. Next slide, sir. Patients' cleanliness services include daily bathing, changing bed sheets, clothes, and hygienic practices such as oral care. Patients are always given a bath either in the tub or in the bathroom before doing the dressing. So the low infectious load is reduced. Blood stain bed sheets are first soaked in 1% sodium hypochlorite solution and then sent for laundry. CVP care and TT care is carried out every day. Aseptic technique is strictly practiced in all respect of patient care. Patients' beds are carbolized every day with spirit or sodium hypochlorite. Instruments used for the patient are washed and kept in Sidex. Next, sir. Infection control in burns ward. Then after every patient clearance, the casualty is fumigated. Those blocks where the patients are admitted, they are shifted to other wards, and all the beds are, all the rooms or the places are fumigated every 4th day. Every 4th day, fumigation of patient rooms are conducted. Fumigation of rooms after patient discharge and death is also conducted. This is the fumigator which they have in the ward. Next, sir. Next slide, sir. Now, this is the bathtub where the bedridden patients are given bath, and at the side of it is the dressing table where they do the dressing. After each dressing, the mopping of dressing room is done. After dressing of all the patients, fumigation is done with Sulfurex. After each bath, the shower trolley is cleaned with Savlon. Next. Infection control in burns. Even if not used, the OT is fumigated every 15 days. The OT procedure are not always carried out. Whenever they are carried out. Even if when there are no OT, they do it every 15 days. The OT is fumigated. Before any case, the OT is cleaned, mopped, and double fumigated. On the day of the case, the OT is carbolized. Fumigation of OT after use is conducted. Next slide, sir. So next slide. These are the solutions which are used in the burns unit. For fumigation, sodium hypochlorite gas or sylvicide in the ratio of 9:1, both in the ratio of 9:1. Then for carbolization, they use spirit or sodium hypochlorite in the ratio of 9:1. And cleaning and mopping, they use Savlon in the ratio of 9:1. Next slide, sir. Next, this is the report of sterility report, which they send every 15 days. So I have interpreted in the next slide. Next slide, sir. So this is the from this report we have seen that depending upon how much is the culture is there in the petri dishes, they have 3 levels: low level, intermediate level, and high level. So around 4 areas of the burns unit on that report had low level of infection, that is a CFU per plate value of less than or equal to 20, and OPD area, ward area, corner 2 and burn OT had a infection of 21 to 50 CFP per plate, which was falling under intermediate level, and there was no area where there was high level of infection. Next, sir. This is the census of the ward. In January, they had 27 admissions, discharges were 17, and expiry was 6. The expiry is 6 not because of any infection, but because of the severe degrees of burns. In February, the admissions were 15, discharges were 9, and expiry was only 3. In the month of March, admissions were 15 and discharges 12 and expiry 4. And also, I have showed in the first slide that in the surveillance they send a tip of the CVP for pathological examination, and when the reports come, they usually find the Pseudomonas candida infections, and they give antibiotics for that. Next slide, sir. So, to conclude with my presentation, I would like to say that well-managed infection prevention and control practices make hospital stay of patients short and lead to early discharge, thereby reducing hospital cost on patients. It is a teamwork, and every individual is responsible for this, even the patient and the relatives. That is why we have seen in burns unit, patients were taught regarding waste segregation on admission. Thank you.
Thank you, Sulaksha.
Thank you, ma'am. Thank you.
Any participants have any queries?
I just wanted to say, Sulaksha madam, you have presented very well with all the details, with all the information which is required to know. And in a very shortly, you have presented each and everything. You have seen all the aspect. Really commendable. Thank you so much. I really like your presentation.
Thank you very much. Because the board is very nice, ma'am.
Yeah.
Staff are very
By
I
seeing
felt
your
like I should present
presentation,
it.
by seeing your presentation, I understood that such a very nice protocols are there, and I hope really they are maintaining that same thing in order
Yes,
to prevent
ma'am.
infection.
The doctor is so personal attention he takes to everything, and very
Yeah.
nice. Earlier,
Okay.
it was so nice.
Okay. Good finish.
Smita ma'am, if no participants have any doubt, then you can leave, ma'am.
Thank you, sir.
Participants, if you like to ask anything before ma'am leaves, please unmute yourself, or you can put it in the chat box if you have any queries. You can unmute here. You can unmute yourself.
I have a question, sir.
Yes, ma'am. To me?
Yeah.
Yes,
See,
ma'am.
in the burns unit, patients get admitted. They get treated. Some die and some survive, and they go home. Of course, with lots of defects, no doubt. But as 3 or 4 days pass, they develop a lot of fever.
Hmm.
Now, according to Madam Sulaksha, she said that the care is very poor those time. What the fever is means that means there is some infection somewhere.
Yes.
Ma'am, what happens how many days after the what is the admission the fever was there?
I had seen in 4 days time only, 4 5 days time only.
Ma'am,
Like
beginning
the fever was not going down.
because inflammation is the percentage of burns is high, they have fever, ma'am, because it's a part of inflammation process. That fever is that is not in time of infection. Infection will set in later on. Dressings are done every day, ma'am. Every day they give patient bath and then they do the dressing. I have seen it. I go to supervise the students over there. And in the beginning, because it's an inflammation all over the body, so when we have inflammation, that is one of the sign of inflammation. So
Because
that
of the
is the reason.
inflammation and pain, probably they get fever.
Yeah, and
Yeah, yeah.
It's
yeah,
not
yeah.
the
And
I
infection that
also
has
they
set in.
no,
I
they
also
give
truly agree.
perfusion for all the patients.
Okay.
They give
See,
Okay, ma'am.
perfusion for the patient in the beginning. So it will remain for some days because of the inflammation. Fever.
I
Thank you, ma'am.
also agree with Suleksha madam because inflammatory process takes place and maybe there are the things that initially you won't see there is a fever or any deteriorating condition, but after when the patient will have that day the patient will not have that much of pain and all, but later on he will get the pain, the inflammatory process will take place, immunity level goes down and the patient will end up with the infection. That is true.
Thank you, ma'am. One more question, ma'am. That since they are given total bed rest and dressings and all are being done, do they develop something called hypostatic pneumonia? Is
Hypostatic
there any
pneumonia
physiotherapy given, chest physiotherapy or something like
is physiotherapy, as I have said, ma'am. They have the physiotherapist in the ward itself. Occupational therapists are there, physiotherapists are there, and sir takes all these people on ground and tell them, Miss rounds are held along with the physiotherapist, along with the occupational therapist. They discuss the case, and every day the physiotherapy is given. Active passive exercises plus deep breathing, and all exercises are given to them. And pneumonia means ventilator patients are not much over there. Very few, means ventilator are not there. They are on the what is that cardiac monitor they put
that?
on
No, no, no. What
CVP.
I said, because the movement of their is
No, ma'am,
restricted. Their
no
movement is restricted, no?
no
Due to
restricted, but they
pain
are
and
no,
this.
no, that's what no physiotherapists are there. They are given physiotherapy every day. Every
They
day
are
they are,
mobilized. They are
yeah,
mobilized.
yeah, they were, and
Okay.
to do dressing, they are taken from the bed to the dressing table. So that
Okay.
time also, and the physiotherapist, and when we go to care, means our students are there, we also encourage them to do active passive exercises, tell them the importance of exercise, all the whichever extremity is affected, especially the joint areas, we tell them with rationale why they have to
Okay.
do, the swelling will reduce, like that we educate also to them.
Any grafting is done, skin grafting
Yeah,
later?
yeah. That
Any
kind of
complications regarding, I mean, following skin grafting?
and complication depends if the patient not much, ma'am, because
No, complications due to infection or something like that, or
no, ma'am, no.
other.
Rare, there will be no, ma'am. It is not 0%, but not too much, because if the patient is sent home after grafting, soon then it comes. But in the hospital, no, because sometimes the patients are sent home first, and then they are after the wound healing only they do the skin grafting. So Afterwards, they readmit them and they do the grafting. Or if the wound heals fast, then if it is required, they do the skin grafting and then discharge the patient. But the complications are very few, ma'am. It all sometimes depends on the patient's immunity, if the patient has diabetes and all that time, but not because of lack of care. Very good luck.
Okay.
You can go, ma'am.
Yeah, I have been
Sister
once, twice
Margaret
there.
is
It is
there.
very good.
Very Go and
But,
see, ma'am. Go and see
unfortunately,
inside
many
one.
patients die too.
You have to change and go. It's a nice unit.
Mm.
It's a nice unit.
Thank you.
Okay, thank you. Anybody else has any? Oh, okay.
I think if no questions are there, then we all can leave also. Now I'll just ask Alvin sir.
Yes, ma'am. Feedback link is to be shared. Ma'am, you can leave, ma'am.
Okay. Thank you.
Thank you,
Nice to
ma'am.
meet you all.
Yeah, thank you, madam, so much.
Yeah. Thank
On
you so
behalf
much.
of IPO and Goa Nursing Council, we thank Madam Mamase for her beautiful talk that she has given and her time, her preparation and everything. We just
Thank you so
and
much. Sir. Thank you so much. Yeah. Right.
participants has any other question?
So, ma'am, feedback link is shared in the chat box. So requesting everyone to kindly fill up the chat box, fill up the feedback form, please. It's very essential for us. And I hope all the participants have seen one pure example of how to do discussion. Like through discussions only, we will be able to learn something new and some good practices we can learn. So very like how Clevy ma'am and everyone has done, Desai ma'am has just done the discussion. I would like to encourage all the participants also to come up with some discussion points, some questions to the speaker as well, so that more and more discussions are done, and we will have an active learning sessions in the upcoming sessions. Thank you.
Thank you, Sir Albin, for your support and a lot of concern that you prepare yourself almost 1 week in advance. You prepare us till that Saturday. And I'm always late in logging in because I'm very poor on this computers.
Yes, ma'am. Not an issue, ma'am. Since it's only the third session, maybe in fourth and fifth, after fourth and fifth sessions, more and more active interactions will happen. So there is a slight improvement from first session. We have more interactions now. So, and I request everyone to kindly keep your videos on during the interaction at least, so that a speaker and everyone can see each other during the interactions. Thank you.
Yeah, in the next session, I think Madam Avisha is ready. Madam Avisha, are you there?
Yes, ma'am.
Okay, next session will be given by Avisha Naik
Yes, thank you.
on prevention of infection. Should we wind up, sir? And anybody has
Yes.
any questions?
Yes, if anyone have already submitted the feedback form, then you can leave. And if you are doing it, please let us know. The feedback is important for us at least, so that we can improve on ourselves, how to do more improvement in our programs. Thank you. So after filling the feedback, you can leave one by one. Thank you. Ma'am, I think I should wind up
Yes.
now.
Yes, I think all
Sierra
of them
ma'am,
have
after Abhisha ma'am, please see if anyone will be ready after the week of Abhisha ma'am, so that we can get a heads up now. 2 weeks.
Yes, Alvin, I'll try that. Yeah.
And I hope ma'am participants and everyone is easily now recognize how to do the case presentation.
Yeah, they will pick up soon.
Only thing I got to do is how to put a backdrop.